Hello, my name is Sarah Clementi. My research synthesis project was centered on catheter-associated infection rates and how to lower them, and that was at Lutheran Medical Center, which is where I work. I have worked in ICU for 10 years, and throughout those years, there's always been a lot of education on preventing CAUTIs or catheter-associated infections. And so when we had this project, I looked into it and different ways of preventing catheter-associated infections. So for the overview of this presentation, it'll include an introduction, description, and significance of the problem, the PCOT question, summary and search strategy that I used in researching this problem, the synthesis of the literature that I found, and what I came to through reading it all, description of the planned change, my evidence-based change that I want to implement, how I'm implementing it, the evaluation of how it worked, and my data collection, analysis, and plan for dissemination, and finally a conclusion. So for the introduction to this research synthesis presentation, I began at Lutheran where I noticed they were really pushing the CAUTI prevention bundles, and that made me look into their rate, their CAUTI rate, and nationally, Lutheran, where I'm currently working, they're doing a little better than average, but still not perfect. So I developed my problem statement and all of that around eliminating urinary catheter associated infections. And I was very interested in this new research on protein inhibiting catheters, which I'll talk about a little bit more later, and what that can do for preventing urinary catheter infections. So what is the significance of this problem? What is the significance of catheter-associated urinary tract infections? They're linked with an increase in mortality, and according to studies, 70% of them can be eliminated through care. They're this unnecessary preventable infection. With that infection, there is an increased use in antibiotics. Knowing what we know about global antimicrobial resistance, that's something we want to eliminate. If we can eliminate antibiotic use, that is a good thing. So not only does help preventing urinary tract infections help this human avoid this infection, the probable mortality, but also can help globally with this antibiotic resistance. So it is a very important issue, something to really invest in. And then financially, there's also this $5,000 to $30,000 expense that the hospital can occur per infection, and that doesn't include mortality. So it is a very expensive infection for the hospital. It's dangerous for the patient, and then also globally, it's using these antibiotics. So something worth investigating. My PCOT question that I developed: do critical care patients with protein inhibiting urinary catheters compared with critical care patients with standard urinary catheters experience lower rates of CAUTIs in a 9-month period? So initially with this search, I started at the USAHS library or school library and went with decreased urinary catheter infection rates, and I had so many articles, like 1,300. So I used protein inhibiting catheters and CAUTI prevention, and I also used exclusion criteria. I didn't want anything earlier than 2018. I wanted articles that had been peer reviewed, and I actually also only wanted articles published in academic journals. And I used these criteria for a search in ProQuest, PubMed, and multiple others, and also just like Google Scholar, looking at them. And I have my Prisma flow sheet that we developed for this on the next slide, and just how I whittled down through reading the titles and then going through the abstracts and kind of what was prevalent. The information on, and I'll go over this again, the information on protein inhibiting catheters is very interesting, but the science is fairly new, so there weren't systematic reviews on the use of those catheters. There's many systematic reviews on the typical urinary catheter prevention bundles that you'll see in if you work as a bedside nurse in any hospital. They'll have a bundle that they put to prevent urinary tract infections associated with catheters, and those have been studied a lot, but these catheters have not been studied. So I'll go over that again later. Here I added my Prisma literature search strategy diagram where it just flows down with my exclusion criteria and eliminating different studies for different reasons, and kind of how I ended up with my couple studies. Synthesis of literature and support for proposed change. I wanted to do these protein inhibiting catheters very quickly. The idea behind these protein inhibiting catheters is that when you have a typical catheter, standard catheter that you place in the body, there's this biofilm that forms around the catheter, and it creates essentially a scaffolding for bacteria to form and develop and just grow and wreak havoc. So having catheters that they're modified where that biofilm cannot develop, it eliminates the bacterial growth. In the synthesis of my research, I was not able to support using that as a practice. There's just not enough research. It's too new. There was one systematic review, but the systematic review was on experimental data, and it was calling for more consistency in studies to produce more consistency in results, but there's not enough qualitative, quantitative, systematic review. There's none of it really for this protein inhibiting catheter. But the science, the experimental science, is very interesting. I believe there's a study by Anderson is one of my first references. They have a really excellent study that was incredibly interesting to read. But reviewing the literature, the systematic reviews that I did find were more indicative of a bundle of interventions, and not only a bundle of interventions, but being very rigorous in the implementation of that bundle. And I will go over that later in the slide of what that bundle entails. Setting for the planned change. The planned change is the bundle, rigorous implementation of a bundle of interventions or multifocal approach to CAUTI prevention. The problem is that CAUTIs are never more prominent than in the intensive care unit. Not only do critical care populations require urinary catheters more frequently, but they are also critically ill and more inclined to get sick. The proposed interventions include how to clean the catheter, stipulations on when to remove it and to remove it as soon as possible, policies on urinalysis collections to remove any false positives, and having 2 nurses for the placement to ensure sterile technique is performed, and all of those bundles of interventions. So for the proposed change, which is implementing a new rigor to urinary catheter prevention protocols or multifocal bundles, I chose Rogers' innovation model. Excuse me. This model It's about giving new ideas to various groups, and that will ultimately change behavior. I thought that this would be important with CAUTI prevention just because so much of the information has already been taught to bedside nurses, and there needs to be this new rigor and this new enthusiasm, and that needs to be changing some minds. So also, nurse leaders need to evaluate the potential of this evidence-based practice and how it disseminates through the staff. The staff would give objective feedback to the unit leaders. The assessment that the staff would give would be based on the evidence-based practice elements, and these elements are simplicity, compatibility, and the compatibility with existing needs, and observability. Plan for dissemination. Again, there'll be an implementation of a multimodal or bundle of interventions, and all the patients with urinary catheters will be tracked with the electronic charting system. Electronic records have been seen to be very effective for data collection, and also we'll be able to track the incidence of CAUTI in the ICU, or CAUTIs in the ICU. The nurses will be educated and insured for privacy in data collection, and I would use anonymous tracking so as not to collect any patient information to begin with. With this multimodal CAUTI prevention, they would again use this model for change, and then I would collect the data and use a standard deviation, statistical mean of the patients with the new rigor and the new enthusiasm for the bundle and patients before then, and see if there's a difference in the two. In conclusion, the problem of frequent catheter-associated urinary tract infections at Lutheran Medical Center is addressed, and the search and synthesis of the pertinent and quality information was also reviewed. The strategy on how to approach all this information and whittle it down and form this evidence-based practice, and how to implement that change with using Rogers' innovation model. After implementing it, evaluating how it is working with that standard deviation that I talked about in the last slide, and then going over and sharing my results, evaluating how it worked, and was it actually successful. And yeah, that is the conclusion of my project. Does anybody have any questions? You can email me. I included my references in the next couple slides, then my email on the last slide.